Hi everyone, and in this video I'll be discussing parasympatholytics. So in the previous video I think you would have watched parasympathetic, also called as cholinergic system. So in this video we'll be discussing parasympatholytics and what are the important drugs in that.
So parasympatholytics.
Now you know that the cholinergic system, the main neurotransmitter is acetylcholine, and we have basically two important receptors. One is the muscarinic receptor and one more is called nicotinic receptor. Now nicotinic receptor, we have two important subtypes, the NN type of receptor and one more is called NM type of receptor. We know that NN is present in ganglia and NM is present in neuromuscular junction. Suppose if I want to block this NN receptor, that means I am blocking ganglion. So these drugs which block NN receptor, they are called ganglionic blockers. Now the drugs which block NM receptor at neuromuscular junction, they are called peripheral acting skeletal muscle relaxant. So they are called as peripherally acting skeletal muscle relaxant. So classical example, I will give a drug by the name D-tuberculin. Now ganglionic blockers and skeletal muscle relaxant we will discuss in other videos. So in this video we will discuss the drugs which block muscarinic receptor. Now peripheral skeletal muscle relaxant, it is also called as non-depolarizing. So these are also called as non-depolarizing skeletal muscle relaxants. Why they are called like that, we will discuss in a separate video, skeletal muscle relaxants. Now what are we going to discuss is muscarinic receptor. Now if I block muscarinic receptor, what is it called as? Those drugs are called as anti-muscarinic drugs. Anti-muscarinic drugs, or we can also call them as anti-cholinergic drugs. So they are also called as anti-cholinergic drugs. Now remember, you don't confuse with anticholinesterase. Anticholinesterase, they inhibit the enzyme cholinesterase and they increase acetylcholine. So they are cholinergic drugs. So don't confuse with anticholinesterase. And anticholinergic drugs are the one which block the muscarinic receptor. So let us start our journey. The anticholinergic drugs. Yes. Now the main drug, the name is called atropine. Now atropine blocks receptors M1, M2, M3 and even the minor receptor M4, M5. So all the receptors are blocked by atropine. Now please remember, when we use the atropine drug, the problem is you are blocking all the receptor. The meaning is it's not specific to one receptor. That's the reason we had to come up with other anticholinergic drugs which have some selectivity for this receptor. Please understand, atropine can block all the receptor, muscarinic only. It cannot block nicotinic receptors. How do I understand this topic, anticholinergic or anti-muscarinic? Simple. When we discussed cholinergic, we went in the same pattern, CNS, eye, mouth, like that. We'll go like that.
Number one, we'll discuss the system, central nervous system.
Now let us compare. When we stimulate parasympathetic, we were feeling relaxed. Now when we use anticholinergic drugs, what happens? The opposite happens. The person becomes excited. The person becomes excited and he will have hallucinations. He will have delirium. So this is what we see with a poisoning by the drug atropine. Now the source of atropine is a plant called Atropa belladonna and one more plant called Datura. So it can cause excitement, hallucination and delirium. So what we see in atropine poisoning. So that is one important aspect we learned. Second important is a drug which produces sedation as well as confusion, and that drug is called a drug by the name hyoscine. The name is called hyoscine. It has one more name, and that is called scopolamine. Scopolamine. Now, if the patient has sedation and confusion, and also this drug can produce amnesia. So what is the advantage of this drug, hyoscine? When it causes sedation, confusion, and amnesia, the drug can be used in a CNS condition, that is a procedure called narcoanalysis. The procedure is called narcoanalysis, and we use a serum for that, and that is called truth serum. So the drug what we use for narcoanalysis is called truth serum. It mainly consists of thiopentone plus scopolamine. So the point here is, when the person is sedated, confused and amnestic, he is tend to tell the truth. So this is about the narcoanalysis. What we use is hyoscine and thiopentone, and this is a correlation with your forensic and pharmacology. Continuing with the CNS, let me start. Now in the CNS, we know that there are two neurotransmitters. One is called dopamine and one is called acetylcholine. They are in balance. Now tell me a disease where dopamine is lesser. The disease is called as Parkinson's disease. It is called as Parkinson's disease. What is the problem in Parkinson's disease? I told you dopamine and acetylcholine in balance. Parkinson's disease, the dopamine activity comes down and acetylcholine will be in the upper hand. So patient will have symptoms of deficiency of dopamine and increase in acetylcholine activity. Suppose you want to treat Parkinson's disease patient, then you have to suppress the activity of acetylcholine. So which is up, you have to suppress that. So we use the drug called central anticholinergics. So we use the drug called central anticholinergics. Now they cross the blood-brain barrier, and what are those? They are called as benzhexol. Now benzhexol has one more name. It is also called as trihexyphenidyl. It is also called as trihexyphenidyl. Remember, hex here is also there, hex is also here. The second one is benztropine. You read the name, it ends with tropine, so it is related to atropine. And how many bens are there? You see there are two bens. So the next drug is biperidine. So you have two bens, that is bi. So remember biperidine. Then when you lose the bens, you get a cycle that is called procyclidine. So you get a drug procyclidine. So you had two bens cars and now you are owning a cycle. So these are the drugs which are used in Parkinson's disease. Not only Parkinson's disease, certain times what happens, we use drugs which block D2. Even when you block D2, the acetylcholine activity goes up and patient will have Parkinson's disease, and that is called drug-induced Parkinson's disease. Drug-induced, PD means Parkinson's disease. Right? So that is about CNS. So once we are done with CNS, let us come to the eye. What will cholinergic system do to the eye? Constrict the pupil. Now when you block that, pupil will dilate. So let us discuss what happens in the eye. The second one is eye. In the eye, these produce mydriasis, and we call it as passive mydriasis. We call it as passive mydriasis, and also they cause
paralysis of accommodation. So paralysis of accommodation, and we call this paralysis of accommodation by one more name. The name is called cycloplegia. It is called as cycloplegia. The meaning is patient will not be able to see the near object. They are blurred. So one of the adverse effects when we use anticholinergic drugs, patient complains of blurring of vision. Blurring of vision. Okay, fine. Now, why you want to dilate the pupil? Why? I want to dilate the pupil to check the fundus. I want to check how the fundus look like. You want to check the retina? You have to dilate the pupil. Second, if you want to do the refractive error testing, problem is if the patient having refractive error, the ciliary muscles are spasmodic and you will not get a proper power. You will not get a proper power. So these drugs are used. So these drugs, what are the drugs? Let me write. The name is atropine. Now atropine is the longest acting drug. It works for 7 to 10 days. And another drug is homatropine, and it works for 1 to 3 days. And we have a drug by the name cyclopentolate. Cyclopentolate works for 24 hours, or simply you can remember as 1 day. Then we have the shortest acting passive mydriatic. It is called tropicamide. It works from 4 to 6 hours. So the longest acting they can ask in the exam, the longest acting is atropine, and they can ask you the shortest acting mydriatic, tropicamide. So suppose if I come to your clinic and you are sitting in the OPD, what will you give? Obviously tropicamide, because it's very short acting and within 4 to 6 hours the blurring of vision will not be there. Suppose you gave atropine to me, what should we do? How do you overcome mydriatic? Then to overcome mydriasis, we use drugs called myotics. They can overcome that. So the longest acting is atropine, shortest acting is tropicamide. We have a separate video. We can see the video called mydriatics and myotics, where we have dealt extensively there. Now where do I use it? These are used, number one, in refractive error testing mainly. Refractive error testing. The second important use of these drugs, they are used in fundoscopic examination. Fundoscopy. So the source of atropine I told you is Atropa belladonna. So these are the drugs which causes mydriasis and paralysis of accommodation, called as cycloplegia. So we are done with CNS, eye, and coming to the mouth. We all know that cholinergic system causes increased elevation, but when I block that, what happens? In the mouth you see dryness of mouth. So cholinergic drugs were causing increased secretion, but anticholinergic drug, the adverse effect is dryness of mouth. Vestibular system also has cholinergic receptors. So let us discuss that. Fourth important is the discussion on the ear. So in the ear we have the vestibular apparatus. We have the vestibular apparatus, and it is supplied by the muscarinic as well as histamine receptors. Now this is connected to cerebellum, and from cerebellum it is connected to the vomiting center. We all know that vestibular apparatus is the one which is required for balance. Now for certain people this vestibular apparatus is hyperactive. Suppose when they are going in a uphill or when they are going in a bends of the road, their vestibular apparatus get activated, the cerebellum gets activated and they start vomiting, and we call it as motion sickness. So the culprit is activation of muscarinic as well as histamine receptor. So what should I do? I have to block that. Now the anticholinergic drug is called hyoscine, which blocks the muscarinic action, and hyoscine is used to treat, not to treat. Remember, it's used to prevent motion sickness. Write down hyoscine to prevent motion sickness. Now please understand, they will not treat. Already motion sickness has occurred, patient is already vomiting, then they will not work. So they will prevent it. How is hyoscine available? Hyoscine is available as a tablet, and it is available as a patch. So you can give a tablet before the journey or apply the patch before the journey. So usually patch works for 3 days. Patch works for 3 days. So that is hyoscine. And we also discussed hyoscine in a topic called antiemetic extensively. So that is about the ear. The next one is heart. So what happens in the heart? You know that collinear system decrease the heart rate and decrease the conduction. So when we use a drug such as atropine, which will block the muscarinic receptor, so what you see is increase in heart rate and increase in conduction in the heart. Now can you tell me, where can I use this advantage? Where you want to increase the heart rate, where should I use atropine? Obviously, when the heart rate is less, bradycardia. And when the heart is not conducting properly, that is called AV block. So it is used in bradycardia AV block. The drug is atropine. The drug is atropine. Now what is the adverse effect? Obviously patients will have tachycardia. The patient will present with the adverse effect tachycardia. Now moving on to the sixth one. So what happens in the lungs? If you remember, cholinergic was bronchoconstrictor. If I block cholinergic system, particularly if I block M3 in the lung, what you see is the opposite, bronchodilation. What we see is bronchodilation. Now where do you want to dilate the bronchus? Obviously in the case of COPD and bronchial asthma. So what are the drugs? What are the drugs? The name is called ipratropium bromide. You read the name, it has tropin in the name, ipratropium. One more drug is called tiotropium bromide. So these two drugs, now where do you use them? They are mainly used in the management of COPD, and they are also used in asthma, but they are mainly used for COPD. Sir, why COPD they are preferred? Point number one, COPD, the cholinergic tone is high. Vagus is cholinergic and the tone is high. So how do you overcome that? Block it. And in COPD, chronic obstructive pulmonary disease, the larger airways are affected and they are better dilated by anticholinergic drugs. The second question is, sir, why not atropine? Why are we using this? Atropine is non-specific. It acts on all the receptors. We want the drug to work mainly on M3 receptor. Second, atropine interferes with ciliary motility, and it will not allow the secretion to clear properly. So that's the reason the specific drugs are used in the management of COPD and asthma. The name is ipratropium and tiotropium bromide. Now, another important drug I just want to discuss here is The drug name is glycopyrrolate. Now glycopyrrolate is used as pre-anesthetic medication. So glycopyrrolate is used as pre-anesthetic medication. You know meaning of it? Anesthesia. Before you give anesthesia, before that, a day before that or before the anesthesia, we give the drug. Now why are we giving? Glycopyrrolate is an anticholinergic drug. We all know that. And it is a quaternary compound. So quaternary compounds usually don't cross the membrane easily. So it will not cross blood-brain barrier. Okay sir, that is fine, that is pharmacokinetics, but why are we using it? Since it's an anticholinergic, it decreases secretions from the stomach, from the saliva, from the salivary glands, and also decrease secretion in the lungs. Sir, what is the advantage? Advantage is when we are putting a patient in anesthesia, many a time the stomach secretion, salivary secretion, they can pool and they enter the lung, and that we call it as aspiration pneumonia. So the advantage of using it before anesthesia is it decreases the chance of aspiration pneumonia. That is one advantage. Second important advantage is the drug decreases reflex bradycardia. What do you mean by that? When we are doing surgery, sometimes the vagus gets stimulated, and vagus is cholinergic, bradycardia can happen. So bradycardia can happen. So how do you overcome that? When we already have anticholinergic drug, they cause tachycardia and they can overcome this. That is the reason the drug glycopyrrolate is preferred as pre-anesthetic medication. The question here is, why not atropine given as pre-anesthetic medication, and why it is less preferred? The reason is atropine can cross the blood-brain barrier, it can enter the brain, and it will do all the things, but the problem is when it enters the brain, you know that it causes delirium, confusion, hallucination. Tomorrow you have surgery and you are given atropine to the patient and he will be hallucinating, he will be delirious, confused, and he will run away. So that's the reason we use glycopyrrolate as pre-anesthetic medication. So once we are done with the lungs, let us come to the GIT. In the GIT, stomach. And stomach, we have the parietal cell, M1. You know that when you stimulate M1, cholinergics cause increase in HCl. But when you block M1, there is decrease in HCl secretion. Now can you tell me, where do you want to decrease HCl secretion? Obviously patient with gastritis. So what are the drugs, anticholinergic drugs we use? They are called pyrenzepine, and one more drug is called telenzepine. So these drugs are used in a condition called peptic ulcer disease. So PUD stands for peptic ulcer disease. So whenever the gastritis increases, the duodenitis increases, there is a formation of ulcer, and we call it as peptic ulcer disease. Now once we are done what happens in stomach, let us come to the intestine. You all know that cholinergic increases the motility of intestine, opens the sphincter. Now if I block that muscarinic receptor, obviously what happens in intestine? Decrease in motility, and there is closure of sphincters. So what happens if the motility decreases and closure of sphincter? What happens? Obviously patient will have adverse effect, and that is called as constipation. Patient will have constipation. But tell me which condition I have to use anticholinergic drug to do this decrease in motility. Now what are the drugs? First of all, let us understand. The drug name is hyoscine. We have hyoscine, then clidinium, and a drug called dicyclomine. Now these drugs are used to decrease motility, and when the motility increases, they are used whenever there is abdominal colic. So if there is abdominal colic or spasm, then we have to use them. Now I'll give an example, guys. One patient came to the hospital and he had abdominal colic and spasm. Now in that case, hyoscine was given to the patient. When the hyoscine was given, he went out and suddenly came, "Sir, I am not able to see anything." Now tell me why he told like that. Why he couldn't see anything? Pause the video and answer this. The reason is simple. These are anticholinergic drugs and cause blurring of vision. And after some time it will get corrected. So you have to tell the patient after injection, wait for some time. So they are used in abdominal colic and spasm, and they are also used to relieve the biliary colic. So anticholinergic drugs are effective in biliary colic as well as biliary spasms. They relieve it. Now the specialty of dicyclomine is also used for one more condition, that is called dysmenorrhea. You all know what is dysmenorrhea? It's a painful menstruation condition, and it relaxes that uterus and decreases the pain. So these are the drugs in the intestine. Okay, so after we understood what happens in intestine, let us understand what happens in urinary bladder. So urinary bladder. Now we know that collineal system increases urination, so the bladder contracts, sphincter opens up. But when you use anticholinergic drug, the urine stays inside, the bladder will not contract. So we use a drugs which will stop the urine, which will decrease the urine, or what we call it as, the drugs cause urine retention. So remember, anticholinergic drugs, they can cause urine retention. They can cause urine retention. Now where do you want to retain the urine? The urine retention is useful when you treat a condition called overactive bladder. The condition is called overactive bladder. Now what do you mean by that? The condition is simple. Suppose somebody has a condition called urinary tract infection. When the urinary tract infection is there, the bladder keeps on irritating. So it starts irritating. So every 5 minutes, patient has to go to the toilet. He has to empty the bladder, come back. So those conditions are called as overactive bladder. And we use these drugs, anticholinergic drug, to treat the condition overactive bladder. So let us understand what are the drugs used for overactive bladder. Now please understand, urine retention is an adverse effect of anticholinergics, and we use it to treat overactive bladder. See how the things are getting correlated. So what are the drugs for overactive bladder? OAB stands for overactive bladder. So the anticholinergic drugs you can remember by the mnemonic friend, dost. So the mnemonic is friend and dost. Obviously when you have overactive bladder, we require a friend as well as dost. So F stands for a drug by the name flevoxate. And we have one more drug called fesoterodine. We have a drug called fesoterodine. D stands for darifenacin. Darifenacin. O stands for oxybutynin. And S stands for solifenacin. Now, when we use an anticholinergic drug, they can also block other receptors also, like M2, M1. And the selective drugs for bladder are darifenacin and solifenacin. They are also called as vesicoselective drugs. So they are more specific to the bladder And when they are more specific to the bladder, the adverse effects are obviously less. Now, what is the adverse effect of these drugs? Obviously, the anticholinergic adverse like dry mouth, blurring of vision are very common. And that is very less because these are vasoselective and the name end with phenacin, dari and soli. Now the T stands for trospium. Now trospium specialty is it's a quaternary compound. Now quaternary compound will not cross blood-brain barrier. So since it doesn't cross the blood-brain barrier, the central anticholinergic effect is not seen. Suppose a patient has Alzheimer's disease, and we know that in Alzheimer's disease, the acetylcholine levels are less. And we don't want to give anticholinergic drugs in Alzheimer's disease. Suppose a patient with Alzheimer's disease has overactive bladder. And if you want to prefer that, you prefer trospium because it doesn't enter the brain and doesn't decrease the acetylcholine activity. Another drug is by the name tolterodine. So we have fesoterodine and tolterodine. One more specialty I will tell you. Fesoterodine will give rise to tolterodine. And remember, fesoterodine is a prodrug. So it's a prodrug. You know, prodrug is inactive after metabolism, it becomes active. So this is the point. So please remember the end with pterodines or the end with phenacins. Other things you have to remember is flevoxate, oxybutynin and trospium. I will tell you the mnemonic again. Friend, dost. F for flevoxate, fesoterodine is a prodrug, D for dariphenacin, O for oxybutynin, S for solifenacin. Remember, phenacins are vasoselective drugs. T for trospium, which doesn't enter the blood-brain barrier. Then tolterodine is one more drug. So once we understand the drugs for overactive bladder, next there is one more anticholinergic drug. And the name is called valethamate bromide. Now this is used in cervical ripening. So when do you want to ripen the cervix? During induction of labor. So in this video, we discussed the concept called antimuscarinic, also called as anticholinergic. We went in a systematic manner so that you correlate cholinergic and anticholinergic easily. So we went with CNS, eye, mouth, vestibular apparatus, heart, lungs, stomach, intestine, the bladder, and even the uterus. So a conceptual manner we understood this. Now most of your exam question is based on atropine. So let us discuss some important point about atropine. Let me summarize the things. What are the uses of atropine? So uses of atropine, let me write in the heart. In the heart we use it in two conditions. What is that? To manage a patient with bradycardia and a patient having AV block. Second, you can use atropine in case of poisons. So which poisons we can use it? We can use it in OP poison, organophosphate poisoning, then carbamate poisoning, and early mushroom poisoning. So these poisons we use atropine. Remember, atropine is not useful in one poison. They can ask you as an exception, useful in organochlorine poisoning. So we understood where to use it in the heart condition. We use it mainly in the poisoning. Now remember, it's the drug of choice for all these three poisons: OP, carbamate, and early mushroom poisoning. Number 3, in the eye, we know that atropine is longer acting. It's a passive mydriatic and produces cycloplegia. But are we using it in eye? Yes. We are also using it in eye for refractive error testing, particularly in children less than 5 years. In children less than 5 years, if you want to do refractive error testing, then we are using atropine. You may ask a question, sir, if atropine is longer acting mydriatic, then why are we using it? Please understand, children's, the ciliary tone is very, very high. The tone of ciliary muscles are very, very high, and we want the most efficacious drug, and that is called atropine. Sir, won't the children have blurring of vision? They will have, but the parents will take care. So you have to use atropine in them. Second important condition where we use atropine as eye drop is fungal corneal ulcer. Now the reason is, in fungal corneal ulcer, there is pain. Pain is because of ciliary spasm. And also the atropine has local analgesic property. So because of this reason, it is used in fungal corneal ulcer as well as children less than 5 years for refractive error testing. So these are the important conditions where we use atropine mainly. Now once we understand the use of atropine, they will ask you atropine poison. So atropine poisoning, what you see, or it is also seen as anticholinergic poisoning, overdose. So they represent like this. Now if you remember dumbbells, when you discuss that in OP poisoning, so the opposite occurs in this. So let us write dumbbells first. So when you stimulate M, we see the dumbbells, diarrhea, then urination, then meiosis, yes, bronchoconstriction, bradycardia, yes, then what? Emesis, lacrimation, and salivation. So this is what we see when the muscular receptor is stimulated. Now when we give atropine, this action is done. So in atropine poisoning, what you see, the patient complains of constipation, urine gets retained, urine retention. So patient will present with mydriasis, and they can cause bronchodilation and they can cause tachycardia. Patient will have decrease in secretions. He will have decrease in secretion. And what about sweating? Atropine causes atropine fever. Now what do you mean by atropine fever? Why there is fever? Now let me explain that. Now we have a simple concept that sympathetic fibers. So there are certain exceptions for that. Even though they are sympathetic in origin, the fibers are cholinergic for a gland called sweat gland. So sweat glands, they have cholinergic fibers which release acetylcholine, which acts on M3 receptor, and patient will have sweating. Now these sweat glands are called as thermoregulatory sweat gland, meaning they regulate our body temperature. So when the temperature is high, they will increase the sweating, so body temperature goes up. What happens in atropine poisoning? These M3 receptors are blocked, and we don't have sweating mechanism to throw the temperature out. So there is no sweating in atropine poisoning. Remember, there is no sweating seen. Now when there is no sweating seen, how does the body lose the body temperature? By causing vasodilation, and that causes flushing. So he will be red in atropine poisoning. See, remember, atropine poisoning, patient will have constipation problem, urine retention, mydriasis, increase in heart rate, decrease in secretion, fever is high because the body temperature is going up because the sweat glands are blocked, no sweating to remove the body temperature, the vasodilation occurs and there is flushing. Now another important aspect we need to understand atropine poisoning. Whenever you think of atropine, remember the 3 C's. So it can cause convulsions, it is cardiotoxic, it can cause arrhythmia, and patient may go for coma. So when you see the case history, you will see these, particularly check the pupil. If pupil is mydriatic, obviously we have to go for atropine poisoning. Either you can ask it as atropa belladonna poisoning, or it is also called as datura poisoning. So we understood that. But there are some toxidromes, we call certain symptoms like this. In atropine poisoning, we tell a person as blind as bat. Now why we call him as blind as bat? Because he will have mydriasis and cycloplegia, and that will cause blurring of vision. So he will not be able to see anyone. The second important is heart has desert. So person will have atropine fever, and that's why it is called heart has desert. It is also written as mad as hatter. So why mad atropine? Because atropine crosses the blood-brain barrier and it causes hallucination, confusion. So you will be confused. That is called mad. Another important is dry as bone. Now you know that it dries the secretions. So the dry mouth, urine also retained. So dry urine, not dry urine. It is called no urine at all. There is nothing like dry urine. So it is called dry, and red as beet. So red as beet because for flushing. So this is what the typically described for atropine poisoning, that is blind as bat, hot as desert, mad as hatter, dry as bone, and red as beet. So you can get these questions in your exam. Now whenever there is atropine poisoning, what is the antidote for atropine poisoning? Antidote for atropine poisoning. So they can ask you as atropine poisoning, they can ask you as datura poisoning. So any of this poisoning, the drug of choice is physostigmine, guys. It is physostigmine. Don't confuse with pyridostigmine. Pyridostigmine doesn't cross the blood-brain barrier. Physostigmine crosses the blood-brain barrier and kicks the atropine out. So that is the reason the drug of choice is physostigmine. So once we understood atropine and atropine poison, it's important in the future we understand what are the anticholinergic adverse effects. Anticholinergic adverse effect. So in the future, if I tell you anticholinergic adverse effect, these things should come to your mind. So let me summarize. Patient will have dry mouth, then in the eye, blurring of vision, then constipation and urinary retention, and tachycardia. So tachycardia can also lead to arrhythmias. So these are the problems with anticholinergic. So future, if I tell a drug blocks muscarinic receptor, that means you should remember these are the adverse effects. Another important point you need to keep in your mind, what are the contraindications where you should not use atropine or anticholinergic drugs. So remember, it should not be used in elderly patients. Point number 1, a male elderly patient already has benign hypertrophy of prostate, and these drugs cause urinary retention there. Already the urine is not coming because of big prostate, and if you give them, it will cause further urinary retention. Second, in elderly it will cross the blood-brain barrier and cause confusion and all these things. So we don't want to use it in BHP, benign hypertrophy of prostate, where the urine is already retained and the anticholinergics also retain urine. and it is not used in angle closure glaucoma. So problem in angle closure glaucoma is the angle between iris and cornea is closed. So if you use mydriatic, the angle will close further, and that may trigger complication called acute congestive glaucoma. So angle closure glaucoma, any mydriatic should be avoided. So that is about the anticholinergic drugs. Let me summarize. So we went in a systematic manner. Remember, in the CNS, atropine causes confusion, delirium, and that is what we see in atropine poisoning. In the eye, it causes mydriasis. We use it in fundoscopy and refractive testing. It can cause dry mouth as adverse effect. It can suppress a vestibular apparatus. We use hyoscine in motion sickness. Heart, it increases the heart rate and increases the conduction. So we use it in bradycardia and AV block. Lungs, they dilate the bronchus. Hypertropium, tioprotropium, used for COPD. In the stomach, they decrease HCl. We use it in gastritis. The name is pyrenzapine, tilanzapine. Intestine, they decrease the motility. We use it in abdominal colic and spasm. Example is hyoscine, dicyclomine, and clidinium. Bladder, they retain the urine. So that is the adverse effect, but we can use the condition in overactive bladder. The mnemonic is friend dost. Valithamate bromide is used for cervical priming. Then we discussed the uses of atropine in heart, in poison, and it is not useful in organochlorine poison. And one more, it is used in eye condition like fungal corneal ulcer to check refractive error in children less than 5 years. Then atropine poisoning, the drug of choice is physostigmine. They can also ask the thorough poisoning. Now, what are the anticholinergic adverse effects? Dry mouth, blurring of vision, urine retention, constipation, tachycardia. What are the contraindication? Elderly, BPH, and angle closure glaucoma. So that is about anticholinergic drugs. Thank you all.